So hello everyone and welcome and good evening. My name is Dr. Om J. LAKHANI and yeah, so we are here we'll be starting in just a few minutes. We'll be starting at 8:30 sharp. So welcome to the MASLD Pro sponsored by LIPAGLYN. Name is Dr. Om. Okay. All right. So I think it's time to go. It's 8:30 p.m. So we should start this program straight away. So good evening, everyone. Welcome to LIPAGLYN Zydus MASLD Pro 2025. This is probably the most current and comprehensive course on the field of MASLD. I'm going to go through, today we are going to go through a series of things. We'll go through the introduction to the entire course, but we'll also be going through some of the very useful, lectures. So we're going to have 3 lectures today. We'll also introduce you how you'll be using the course throughout how you'll be using our platform for the entire course. So we'll be going through this. So let's begin without much ado. We are 8:30 and we are live. So I'm Dr. Om J. Lakhani. I'm a consultant endocrinologist at Zydus Hospital, and I'm the founder of technocrinology.com. So this is the course which you're attending today. That's the first part of the LIPAGLYN MASLD Pro 2025. Now, this is a 4-part series. So we are going to have 4 1-hour lectures. We are going to have the first part, which is today. We're going to have the next part, which is on the next Tuesday, and then the Tuesday after that, and the Tuesday after that, right? So it's going to be a month-long course. We are going to have 4 lectures, 4 chapters rather, and each 4 parts, and each part or each chapter will have sub-lessons, generally about 3 or 4, right? So it will be a 1 hour, approximately an hour session each. Now, these are today's topics. We're going to discuss about definition and nomenclature of MASLD in great detail. We're going to discuss about pathogenesis and pathology of MASLD, and we'll follow the first principles approach. So I understand a lot of you who have joined are mainly clinicians. Mainly you would be either a physician or a diabetologist or endocrinologist or a hepatologist, or whatever field you are from. Mainly you're looking at clinical aspects. So we'll be mainly focusing on the clinical aspect of pathogenesis and pathology. And the third lecture, which is something very interesting, will be liver as an endocrine organ. So we'll see why liver has connotations and attachments with the endocrine system, and why most of the treatment that are now introduced for MASLD are mainly dealing with the endocrine system. So very importantly, more important than the lecture itself, we are going to introduce to, so this is our second series on the Technocrinology platform, second live series. We have had other courses on the same platform. But in technocrinology.com, though the name suggests Technocrinology, we actually have a sort of a mixed blend of the old ways of learning and the new ways of learning. And one of the old ideas which we have incorporated in our technocrinology.com platform. So it's this course which you're going to attend. Not only is you're going to learn a lot about MASLD, but you'll also learn a lot about how how new age technology can be leveraged for teaching new age medicine. That's the other underlying current to today's lecture. Now, what we generally have started embracing in the technocrinology.com platform is the Vedantic learning methodology, which involves 3 very concrete but beautiful steps. The first step of learning is Shravana. That is what we are doing right now. So that's basically listening attentively to the teaching. So you'll be listening to what I'm going to teach you. You'll be also reading a lot of material which will be there on technocrinology.com platform. So most of the things we are going to discuss that will be given to you in that will be there on the platform in form of notes. The second aspect will be Manan, and Manan is basically self-reflection. So I'll show you the self-reflection aspect of which is embedded in the platform itself. And the third part is what is known as Nidhyasan, which is basically the final step, and that is utilizing the knowledge. So whatever knowledge you've gathered from the lectures, how you can utilize in your clinical practice. So that is basically what is Nidhyasan. So you're going to embrace all the 3 aspects of this learning in this single platform. So every course on this platform is going to have 2 parts. One is the chapter. So this is chapter 1. Okay, you can call it part 1 or chapter 1. There are 4 chapters, as we broadly saw in the first slide, and each chapter has lessons within it. So today we are going to cover 3 lessons, and then subsequent chapters we are going to have more lessons. Okay. Additionally, there will be additional components to it. So there will be quiz. So we'll be running some quiz questions live here, as well as we'll be having the same questions on the technocrinology.com platform. We'll be doing something which is called Manan, that is reflection of learning, which is mandatory for everybody, right? So remember, this is a certificate. You will receive a certificate of participation, but to receive the certificate, you will have to do a little bit of reflection of your learning. I'll show you how to do that. And then we'll be doing Nidhyasan, which is basically we have developed some mini applications that are important for you, as well as you can use it in your clinical practice. These are all there on the platform. So you can use that. We'll show you the mini applications also and how you can use the knowledge you have gained in your clinical practice. So the lessons will be of several types. There'll be text-based lessons, which I'll show you. There'll be videos like the current presentation, which I'm having, which will be uploaded on the system in a few days. There'll be certain standalone presentations without the video. We'll be having the reflection part, which is the assignments. There'll be the toolbox, which is the Nidhyasan. There'll be quiz, and the final, after the 4th lecture, the 4th lecture of the 4th chapter, there'll be an exam, simple exam, multiple choice questions. You'll have to again go through that and successfully pass it to get your certificate of participation. So we'll be taking questions in the end. So if you have any questions, please put it in the chat box. Okay, now I'm going to show you how the platform looks like, right? So there are two aspects of it. One is the live lecture which you're attending, which will be there on the Zoom platform. The same is going to be broadcasted on the Endocrinology India YouTube channel. So you'd have received an email from Zoom and the channel link is there. So you can go there. But whatever we are going to teach will be there on the platform. So I'm going to show you how the platform looks like. So what you have to do is, if you're not done so already, you have to go to www.technocrinology.com. Okay. And once you go there, you will get the access to the lecture. Give me 1 second for it's loading. So when you go to the system, it'll take some time for it to load. It's okay. When you go to the system, you'll have presentations which will look like this, and there are buttons in the bottom for next. There'll be a lot of text-based things. You can also access all of these through the mobile application also. So you'll have to download the mobile app called Thinkific. Okay, so this is the application you have to download. You need to search for Technocrinology. And once you search for it, and you'll have to use your own email, the email address which you used for signing up here, to then sign up, and then you will be getting the access here. You'll be able to access the same thing what we are having on the web application, on the mobile application also. Okay. So this is what it look like. And in the end, like I said, if you do the entire course, you will get a certificate of participation. There'll be an exam, short exam, which you'll have to give. Okay. So this will how a certificate of participation would look. So this was the first part about the introduction to the course. And thank you for listening. And now we'll move on to the main course itself, right? The main lectures itself. Again, like I said, I'll be happy to take any questions. So if you have any questions, please put it. There are about 180 participants right now. You can put your questions in the chat box. In the end, if we have time, we'll be asking you to unmute yourself and you'll be able to ask these questions live. But if you have any burning question, just put it in the chat box. And as I go through the system, I'll be happy to answer that. Okay. Just let me show you the platform real quick. Yeah, so this is what it looks like. So it's called technocrinology.com. And once you'd have signed up for the course, so you can, or otherwise you can search for it, the LIPAGLYN MASLD Pro course. When you click on it, you will be taken to the course page, right? So here I had already started, so it should be resume course. Now you'll need to come and check this every week because we'll be putting the new content regularly. And yeah, so this is what the course would look like. Okay, and these are the topics we are going to cover in this week, right? So you can see here the chapters and all the notes that are there, whatever we're going to talk will be there in this as notes. We'll be also putting up the presentation. There'll be quizzes here, like you can see the quiz over here. Okay, and there will also be there'll be also certain extra additional notes. So you can see there are some additional notes also here with references. So you can see some additional notes on the topic also. Okay, so you can go through this as well. We'll be covering only 3 lectures today, but the other things are available as notes. So we'll not be covering that. But this is the part. This is the reflection part. So at the end of this, you will have to, there are certain questions we want you to answer about what you learned, how you'll use in your practice. So this is called Manan. And there'll be something called Nidhyasam. This is the exciting part, right? This is where technology meets endocrinology. So we'll be giving you some, useful applications like this, which you can use for your day-to-day practice, and you can continue using that in your practice. Okay. Now, let's begin with the first lecture, and that is definition of MASLD. So I'm sure you would have a lot of questions. Please put them. Don't raise your hand. Just put your question in the webinar chat. Or if you're watching this on the YouTube platform, you can put it on the YouTube chat as well, right? So we'll try and answer that questions as we go along. So let's begin with the first chapter, first lesson. Yeah. So now, first you'll ask me, Om, why MASLD? What's the fun part of MASLD? Why MASLD and why at this point of time? Now, I very strongly believe. Now, I'm sure if you're looking at the lot of literature these days, there is now Lancet has come with the new definition of obesity. Lancet now there is now emerging evidence of adiposity, the disease itself being adiposity. And adiposity is the precursor of a lot of the chronic metabolic diseases that we see. For example, type 2 diabetes. We'll see how MASLD joins with type 2 diabetes. You have heart failure or HFpEF, heart failure with preserved ejection fraction, PCOS. All these diseases have a common link. The common link is basically adiposity. And hence, if you understand MASLD, I think MASLD is one of my favorite topics. If you understand MASLD, you understand some aspects of all the chronic metabolic diseases. So that's the reason why MASLD is a very important disease to understand. Also, very importantly, MASLD, a lot of the literature has changed, a lot of evolution has happened in this field, and a lot of treatments are now available for patients with MASLD. A lot of these treatments have endocrine correlation, right? So a lot of the principles of these treatment are based on endocrinology principles. So that's why it's very important to understand MASLD, and it's also very important to understand MASLD from an endocrinologist perspective, because like I said, most of the treatment are, that you're going to offer to your patients are endocrine treatment. So this course is, of course, if you see if the same course was designed by a hepatologist, there'll be different aspects of it. If the same course was designed by, let's say, a physician, there'll be different aspects of it. But this course is designed by an endocrinologist, so you're going to mainly focus on the endocrine aspects. And those are the most important, according to me, because those are the future of the treatment of MASLD. Okay, so that's why MASLD is very important and one of my favorite and very burning topic. And I think, like I said, if you understand MASLD, you understand chronic metabolic disorders. So the nomenclature, now this disease, this is the artist who used to be called NAFLD. This is the artist who used to be called fatty liver, right? All these things. Now the stable terminology is MASLD. That is metabolic dysfunction associated steatotic liver disease. Then the more severe version of that, or the one with hepatitis, is called MASH, that is metabolic dysfunction associated steatohepatitis. And then there's a condition called MetALD. We'll come to these terminologies in a minute. Let's now look at a little bit of the history. So in 1980, Ludwig was the first person who described the term NAFLD. Now in 2020, they changed the term from NAFLD to MAFLD, that is metabolic associated fatty liver disease. They call it non-alcoholic fatty liver disease. Now, when Ludwig originally came with this term, what he wanted to say is that this is NAFLD, which is different from alcoholic liver disease. That's the whole idea. But as we evolved, more and more it was realized that a lot of patients with metabolic disease also consume alcohol. So how are you then going to say that, I'm, only for complete teetotalers are you going to do this? So I think that was the term non-alcoholic was a little misleading. And hence the term metabolic associated, or MAFLD, was proposed. So the term MAFLD then stood. But then the term fatty or the fatty liver has a lot of negative connotations again. And hence the term fatty was replaced by steatosis or steatotic. So the current terminology changed from NAFLD to MASLD and NASH to MASH. Okay. So the term fatty was replaced by steatotic. And then a new category was introduced, which is called MetALD, that is metabolic associated with alcoholic liver disease. So we'll discuss this term and we'll understand how all these terms really fit into the picture. Okay. Now, is it a common disease? It's unfortunately very common. 33% of the adult population in the world has MASLD. So it's a big problem. It's a big problem. And that's why it's very important for all of you, kudos to you. You came here to learn this. It also has links with all the traditional risk factors: obesity, overweight, type 2 diabetes, alcohol consumption. There are certain genetic predispositions also. So it has a link with the classic metabolic syndromes. Now, let's first define MASLD. Okay, MASLD disease itself. So that what was previously known as NAFLD. So we'll first define MASLD. So what is MASLD? Now, MASLD, the first criteria that there should be presence of hepatic steatosis. That is, ideally, if you do a biopsy, more than 5% of the liver should have hepatic steatosis. But generally, we are not going to do biopsy in all patients. So what you can generally say is that you can say that if you have an ultrasound, you have fatty liver. Or the other things, we'll see the diagnosis of and screening of steatosis in the next chapter, which is the next week. Secondly, there should be presence of the cardiometabolic risk factors. What are cardiometabolic risk factors? Your classic cardiometabolic risk factors, which are part of the metabolic syndrome, that is elevated triglycerides, low HDL, hypertension or pre-hypertension. If you have insulin resistance, so you have pre-diabetes. So these are all classic, symptoms of metabolic syndrome. Then you have a limitation on alcohol. Okay, so again, somebody who is having MASLD is not completely a teetotaler. He's not somebody who has never touched alcohol. But the alcohol consumption here, if it is MASLD, the alcohol consumption should be less than 20 grams a day for females and less than 30 grams per day in males. And finally, remember, this is a diagnosis of exclusion. So all the other causes of liver disease should be ruled out. And we'll see that in the next chapter 2 about the differential diagnosis and what things you need to rule out. Right? So this is the classical definition of MASLD. Now, then there is a terminology called MASH. Now, when I say patient has MASH is steatohepatitis. Now, I'm going to talk in the very next lesson about what is steatohepatitis. So I'll leave this point over here. So just keep this thing in mind. Then you have MASH cirrhosis. So you have basically the patient then evolving into fibrosis and then developing fibrosis and cirrhosis. Okay. So this is the regular evaluation, which we'll show that picture also. But then the term you have to understand, and this is where the confusion really begins, is the term now which is known as MAT-ALD, which is basically metabolic dysfunction and alcohol-associated liver disease. So what is MAT-ALD? So MAT-ALD means that the patient has all the criteria of MASLD, that is, the patient has steatosis, patient has cardiometabolic risk factors or metabolic syndrome risk factors. You have excluded other causes, but the only difference really lies in the alcohol intake. So when you said that the patient has MASLD, the alcohol intake was less than 20 grams in females and 30 grams in males. But when you talk about MAT-ALD, the patient has moderate alcohol intake. That is about 20 to 50 grams per day in females and 30 to 60 grams in males. So this is the moderate alcohol use. So if you then, go a little deep into the classification and diagnostic criteria, this is the chart. This is there in the, on the endocrinology.com website also. So basically what you do is, what happens to your patient is that you find a patient with fatty liver on ultrasound. You look for presence of cardiometabolic risk factors. And what are the cardiometabolic risk factors? We already told you the metabolic syndrome criteria. Does the patient have cardiometabolic risk factor? Yes or no? If the patient has cardiometabolic risk factor, then you see how much alcohol the patient is taking. Okay. So if the patient is taking less than 20 grams of alcohol, then the patient is said to, or 20 grams in female, 30 grams in male, then the patient is said to have pure MASLD. If the patient is taking moderate amount of alcohol, then the patient is having MAT-ALD. But here comes the interesting part. Now, if the patient has all the things, but the patient takes excess of alcohol, that is more than 50 grams in females and 60 grams in males, then the patient gets classified as alcoholic liver disease and not the other forms. Secondly, now if the patient doesn't have cardiometabolic risk factors, then you look at the patient's alcohol intake, and any alcohol intake, even if it is moderate, more than 20 by 30, that patient is labeled as alcoholic liver disease. And then finally, if you don't have the patient taking enough alcohol, and the patient does not have any cardiometabolic risk factor, then the patient is said to have other causes of steatotic liver disease, which we'll discuss in the next chapter, right? So I hope this is clear. To clarify it further, this is what I made this in a simple way. So this is the key point in the first lecture. Hepatic steatosis with cardiometabolic risk factor is equal to MASLD. With alcohol intake should be low. Now, if the patient has all the criteria for MASLD with moderate alcohol intake, then the patient is said to have met ALD. If the patient has having MASLD with heavy alcohol intake, then the patient gets labeled as alcoholic liver disease and not MASLD. And if the patient does not have anything, right? So patient does not have heavy alcohol intake or even moderate alcohol intake. Patient does not have cardiometabolic risk factor. Then you have to look for other causes of steatosis. And finally, the catch here lies here that if the patient does not have cardiometabolic risk factor, but consumes alcohol in moderate quantity and has liver disease, then it is alcoholic liver disease, right? So this is how you classify the patients in terms of modern classification for this, right? Now, again, this is where we come to the Nidhyasan aspect of it. So on the website, on the technology.com, just to make this thing simple for you, we have made this calculator, simple calculator, which you can use. So to give the correct classification of your patient, right? So if the patient is, let's say, male, patient has steatosis, obviously, patient has a couple of cardiometabolic risk factors, right? Okay, and then you look at the patient's alcohol intake. Okay, so let's say, let's put it as 20, right? So male patient with 20 grams per day. So the patient then gets labeled with MASLD, right? So you can try out a few iterations, and see how the classification changes based on what you do, right? So this is how and this is a good way of learning, right? The entire system. Okay. Next. So alcohol consumption, we already saw this, right? How do you classify? So less than 20 grams is considered minimal for females, 30 grams in males, 20 to 50, 30 to 60 is moderate, and more than 50 grams a day is in females, and more than 60 grams in males is considered to be heavy alcohol intake. Again, you'll ask me what is a standard alcohol intake, what is a standard drink. So this is a rough estimation to that, but again, we have one little nice alcohol consumption calculator. So you do this for your patient to give you again the right classification. Let's say the patient takes about two pegs of whiskey in one session a day. The patient basically consumes 27.8 grams of alcohol. And if you see in these terms, again, 27.8 would be considered as minimal alcohol intake, right? So somewhere like that. So you can then look at the calculations, right? And moving forward, right? Okay. Now, what happens to, so you see this classic chart, what I've done is I've kind of changed it, flipped it around. What is the natural history of steatotic liver disease? So you have steatosis, then here's steatohepatitis, and this is what we'll discuss in the next chapter. Then some patients go on to develop fibrosis, and then ultimately goes to cirrhosis, and then goes to decompensated cirrhosis. And some patients may develop hepatocellular carcinoma also. Remember, this is a risk factor for HCC as well. So let's look at the first quiz, and let me just raise the quiz for you. Okay, so you'll see a quiz being flashed on the screen. Right now, it would be a great idea for you to take part in this quiz, right? Because it kind of helps you keep engaged with the thing, right? Okay, so we have put this question here. 45-year-old male patient has history of obesity and dyslipidemia, presents with hepatic steatosis on imaging, and reports moderate alcohol intake, that is 35 grams a day. Based on the updated classification, what is the most likely diagnosis? Okay, so a lot of you are trying to answer. Yes. So remember, this patient has metabolic risk factors. Patient is a male. Patient takes moderate alcohol intake, right? Yeah. So all of you, most of you have tried to answer correct. Our 88% are answering this correctly. That is basically this patient will be classified as MAT ALD. Okay. So still there are a lot of people answering. So while people are answering, let's take a couple of questions if they are there in the right. So a couple of people have raised their hands. Like I said, we'll be asking you to answer. I mean, we'll be allowing you to ask questions, but till then you can if you have any query, you can put it in the chat and we'll be taking that over, right? Right. So most of you answered it correctly. This patient will be classified as having MAT ALD, right? Again, we showed you the, yeah, I think there are, okay. Yeah, no, not the chat, in the Q&A, right? Somebody has, Chandan Kumar has said chat is showing disabled. Yes, chat will be disabled. You can put your questions in the Q&A section, right? Okay. Gopal has just shared the website and app details. Website is called technochronology.com. Okay. So you can go there, and the app is called Thinkific. Okay. So right. So let's end the poll here, and we share the results, right, with you. So again, most of you answer correctly. This patient will be classified as MAT ALD. Why? Because patient has hepatic steatosis, patient has presence of hepatic cardiometabolic risk factor, patient has dyslipidemia, and then third part is the patient is having moderate alcohol intake. So patient will be classified as MAT ALD. Okay. So again, if you have any questions, put it in the Q&A, right? Put the questions in the Q&A, and we will then move to the second lecture. Just give me 1 second to start sharing that. Okay. So the second part of today's session, what we're going to discuss is we're going to discuss about, this is the main meat of the entire session. We're going to discuss about, sorry. Yeah. So we're going to discuss about the pathogenesis and pathology of MASLD. And we'll take the first principles approach. What is first principles? We'll take the very core fundamental basic things which are useful to clinicians like you and me. So that is what we'll not be focusing on the real pathology, right? I mean, real in the sense, what is important to pathologists. We'll be rather focusing on what is important to clinicians, right? So that's the whole purpose here, right? So that's what we'll be doing. Okay, so let's move ahead, right? Now, let's first understand this concept here. There are two terms. One is steatosis and second is steatohepatitis. Okay. So itis anywhere means basically inflammation. Okay. So steatosis means fat in the liver and steatohepatitis means you have inflammation, right? So basically steatohepatitis denotes inflammation. Now, what is steatohepatitis? Steatohepatitis is very important because unfortunately, that is the middle ground. Okay, that's the unstable situation, right? Where the patient can go back into a state of, non-hepatitis, or patient can go forward towards the state of fibrosis. Okay, so steatohepatitis is the primary driver for the future fibrosis. Why steatohepatitis is very important? Because nowadays, now you're going to see a lot of clinical trials being done for MASLD. And most of the clinical trials now want inclusion at the level of steatohepatitis. Unfortunately, the biggest problem with steatohepatitis is that there are no clear biomarkers or non-invasive surrogate markers for diagnosis of steatohepatitis. So you're dependent on only biopsy. Only with biopsy, you are able to give a confirmatory diagnosis of steatohepatitis. Now, of course, there are other ways in which you can, make a diagnosis, and we'll discuss that in chapter 2 in the next week. But right now, what you have to understand is that there is no one classic surrogate marker of steatohepatitis. And unfortunately, steatohepatitis is a primary consideration for drug clinical trials. Okay. Now, what are the pathologic features of steatohepatitis? Steatohepatitis should have steatosis. There should be lipid droplets in hepatocytes. There should be inflammatory cell infiltration in the liver lobules, and there should be hepatocyte ballooning or cellular swelling. These are three key histological diagnostic characteristics of steatohepatitis. So there should be fat, there should be inflammation, and there should be ballooning. If these three things are there, the patient is said to have steatohepatitis. Now, how does it correlate with other endocrine disorders? The important part here you have to understand is that you have fat, which is steatosis. So take any organ in the body, you will have fat, and then you will have inflammation. Okay, and inflammation is the important part because that is the fat under stress, and this inflammation is the one. This is the thing which also creates a lot of havoc. Also, the good idea, good aspect of it is that this is also the situation which leads to a lot of clinical benefit if you treat this patient, recognize and treat this patient at this stage. Okay, just give me a second. Right, so if you treat the patient at this stage, it gives you a lot of benefit in terms of treatment also, right? So that's the beautiful part of the entire thing. Okay, now moving ahead. Like I said, there are problems with diagnosing steatohepatitis. So you do not have any clear non-invasive methods for diagnosing steatohepatitis. So ultimately, you have to consider going for liver biopsy. Okay, so this is where we run the first. We'll do the quiz in the end of this chapter, right? So we'll just wait for that. So the first important key lesson is steatohepatitis is the important area, not steatosis, steatohepatitis. So just fatty liver on ultrasound is not important. What is clinically relevant is steatohepatitis, but you cannot diagnose steatohepatitis very clearly with all biomarkers. It can be, but we'll see that the nuances of that later, but it is not confirmed. And secondly, the only way you can do it is to use a biopsy. And very importantly, steatohepatitis is a stage where you have to consider treating the patient. And that is a stage also which are considered in clinical trials. Now, what are all the conditions that lead to steatosis? What are all the situations that lead to fat in liver, right? So what are essentially the differential diagnosis of fatty liver? So you have, of course, alcohol related, which you already saw. And then you have metabolic and endocrine related. So metabolic related are these, right? But there are other endocrine conditions which are linked with steatosis, hypothyroidism, and we'll discuss this in the next chapter, which is in detail about hypothyroidism and why liver can be considered an endocrine organ. Cushing syndrome, PCOS, all these conditions you can have. Obesity itself can be linked with hepatitis, with fat in the liver. Rapid weight loss can also lead to fat in the liver. Starvation also can lead to fat. There are certain drugs like valproic acid, right? Methotrexate, corticosteroids, estrogens. These can also lead to steatosis. Genetic conditions like alpha-1 antitrypsin deficiency, Wilson's disease, etc. And then there is other conditions like hepatitis C, right? Or Ray's syndrome, right? So these are all rare conditions. Again, these are areas not to mainly interest to endocrinologists. These are or physicians. These are areas really mainly if you make a diagnosis here, you send it to a gastroenterologist or hepatologist. What we are interested in, these aspects, right? These are the areas where our role primary comes into picture. Okay, now, so what is the deal with this fat? Why does this fat come to the liver, and what really happens, right? Especially for patients with metabolic disease. So let's take it this way. You are a person where there is excess of fat, right? So you start accumulating for whatever reasons. Okay, so it might be lack of physical activity, it could be genetic condition, whatever, right? So where does this fat really get stored in the body? The fat gets stored in specialized cells for storing of fat, which are adipocytes. Now, generally, most people have a fixed number of adipocytes in adulthood. Of course, this number is dynamic, so there could be some adipocytes which are newly formed and some adipocytes which that get destroyed. So there is some dynamicity in this, but mainly more or less the number is fixed. So what happens is that you are then, let's say you are somebody who are movers and packers. Okay, you would have seen movers and packers. So movers and packers bring these boxes for moving all the items. Okay, now let's say your house has maybe 30 items and each box can fit 10 items. So the movers and packers bring 3 boxes. So you have easily fit 10 items in each box. So you have basically, the boxes are basically done, right? So boxes are fixed. Okay, so the number of boxes which the, maybe sometimes, maybe there is there is 35 items, maybe you can borrow your box from your neighbor. So maybe there'll be some dynamicity there. Or maybe you have 20 items and one box the movers and packers takes home. But generally speaking, you will have, a fixed number of boxes. Actually, the mover and packer will not take it home. It actually fill the 3 boxes with less number of items. So that is what happens in adipocytes. So adipocytes are those boxes which your movers and packers basically bring. Now, what happens when the fat, when you have more items than the number of boxes? That is what happens in excess fat. So when you have excess amount of fat, right? And remember, fat is stored in the adipocytes in form of triglycerides. So you have fat storage over there. Now, when you have excess of fat, right? The fat, they start developing inflammation. And this inflammation leads to insulin resistance, right? So what happens is that you have insulin, but this insulin generally, adipocyte is a live organ. It's an endocrine organ, and it responds to external hormones like insulin. But so in normal situation, it responds to insulin. But when you have excess fat and when you have inflammation, there is, for whatever reasons, there is development of insulin resistance at the level of adipocytes. Now, insulin, what it does is, remember what insulin is, an anabolic hormone. Insulin wants you to store. Okay, insulin is like this preserver, sort of destroyer. So in normal situation, when you have adipocytes and you have insulin, and if the insulin is working on adipocytes, insulin forces the adipocytes to store the fat. But if you develop insulin resistance, that is at the level of adipocytes, now the adipocytes are not compelled to store the fat. Hence, there is breakdown of the triglyceride, there is lipolysis, and this extra fat which is there is released into the circulation as free fatty acid. Now, in circulation, free fatty acids are very toxic. So it cannot just move around in circulation. So ultimately, it has to be then taken by some organ and then removed or metabolized. And remember, which organ takes up all of this metabolic stuff, right? It's the liver. Okay, so all this free fatty acid in circulation gets taken up by the liver, and hence the fat starts getting accumulated in the liver. Now, the liver makes an attempt to remove this fat out into the circulation in a more safe form, which it tries to do it by an exportation by VLDL. Now, some people have genetic disorders where the VLDL export does not take place, and hence more and more fat gets deposited in the liver. Right. So this is a fundamental principle here. Right. So I hope you understand. I think I've tried to explain this in as simple terms as possible. Right. So once again, you have adipocyte storing fat. Now, when you have excess of fat and fat under inflammation, normal situation, insulin acts on adipocytes, but then there is insulin resistance. And if this insulin resistance develops, this inhibition on breakdown of fat goes away. So the adipocyte starts breaking the fat and releasing, which is lipolysis, and releasing the free fatty acid in the circulation. And this free fatty acid gets taken up by the liver. That leads to fatty liver, right? And this fatty liver ultimately, right, leads to the further situation that we're going to see. Okay. So this is the fundamental principle of why there is fat in the liver, right? Now let's go to the role of insulin resistance again, and this we already discussed. So insulin resistance, insulin prevents lipolysis, right? Generally speaking, insulin resistance, does the opposite, right? So when insulin cannot act on the, on the adipocytes, then the lipolysis goes uninhibited, and that ultimately leads to the release of fat in the circulation. Okay. Now, what are the second order consequences of having fat in the liver? So far we discussed problem starts with adipocytes. There is insulin resistance at the level of adipocytes. The free fatty acid is released into circulation, gets taken up by the liver. Now, what happens in the liver? Now, the problem is that this free fatty acid, again, like I said, is very toxic. So remember, the free fatty acid, to oxidize this free fatty acid, it has to go through mitochondria. So there is beta oxidation of free fatty acid that happens at the level of mitochondria. Now, whenever you have beta oxidation of free fatty acids, one of the consequences of that is generation of what is known as reactive oxygen species, ROS. And this reactive oxygen species are extremely damaging to any cell. Now, in small quantities, there are antioxidants, which are scavengers and which remove this free oxygen. But when produced in excess quantity, they lead to the damage of the cell, right? So it leads to hepatocellular damage. So, at some stage, fat is fine. But then once it starts getting metabolized, and once the metabolism happens in excess and there is generation of free oxygen radicals, this free oxygen species ultimately leads to the damage to the cells, and that leads to hepatocellular damage. Now this is the stage of steatohepatitis. This is the stage. Now this is make or break situation. Either you reverse it back and you go to, so this is just steatosis and this is steatohepatitis, right? So there could be make or break state. So there could be, you are controlling that, right? And ultimately healing takes place and there is complete healing, right? So there is complete recovery. Sometimes there is partial healing and that leads to chronic liver damage. But especially in certain patients and especially patients with diabetes, there is healing by fibrosis. This is a very, very important fundamental principle. I'm going to come to this in a few minutes again. There is healing by fibrosis, and this healing by fibrosis is the thing that leads to the progression of the liver disease to cirrhosis. So this, of all the problems that we discuss, right? Okay, just set up this. Okay, the problem really lies in terms of the mortality and morbidity of the patient over here. Okay, so there is adipocytes. Again, let me recall adipocytes leading to insulin resistance. There is insulin resistance at level of adipocytes, release of free fatty acid taken up by the liver, beta oxidation of fat take place, right? Liver cannot remove the extra fat, so it starts metabolizing it. Generation of free oxygen species leads to hepatocellular damage, and to counter the hepatocellular damage, there is healing. And in most cases, healing happens normally, but in certain cases, there is healing by fibrosis. And this healing by fibrosis, especially in patients with type 2 diabetes, right? So that's why you have diabetes with liver disease, MASLD, a double whammy, right? And that leads to the progression and fibrosis. Okay, so fibrosis is the underlying problem that leads to further challenges. Now, staging of fibrosis is very important. Again, staging of fibrosis is important from the perspective of clinical trials. So there is traditional 5-point semi-quantitative scale for liver biopsy for staging. Again, you don't need to understand what the stages mean, right? Your pathologist will tell you. But what you have to understand is that these two stages are important. So more than F2 is considered significant fibrosis and more than F3 is considered advanced fibrosis. Now, why do you need to understand this? Because these two stages are where clinical trials are going to happen, right? Clinical trials generally will happen at F2 and F3, right? And that's why it's very important that these two stages are the one which you understand that when somebody says that patient has F2 stage of liver fibrosis, then you understand that this patient, this patient is having significant fibrosis, or F3 is advanced fibrosis. Now, what are the factors that lead to fibrosis? So estrogen and certain deficiencies actually are protective, but certain situations are higher risk factors. So which patients are more risk of fibrosis? So male patients, postmenopausal women, patients with type 2 diabetes, I told you this, and there are certain genetic polymorphisms which lead to more risk of fibrosis. Now, fibrosis is also not the same. So again, earlier people used to think that fibrosis is fibrosis, but no. All fibrosis are not the same. There is perisinusoidal fibrosis and there is portal fibrosis. Now, perisinusoidal fibrosis is early stage fibrosis that results from inflammation. This is good because this can be to some extent reversed. Okay, hence you can actually reverse fibrosis, and that is the fundamental principle of why you have so many new drugs being developed. Because this stage you can actually counter. But portal fibrosis is when you have progressive disease. This mainly involves hepatic progenitor cells, and this leads to more severe form of fibrosis, which is generally not treatable, right? Now, what leads to this portal fibrosis? There are two villains in this entire equation. One is what is known as hepatic progenitor cells, and second are your platelets. And that's why, some of the early situations, actually aspirin may actually be helpful here, right? To curtail the platelet function, right? That's very interesting. I mean, that from a pathophysiological perspective, right? So think about it when you go home. Okay, so this hepatic progenitor cells are some of our villains, actually, if you understand, right? So this hepatic, so this you can see on the left, you have the normal, liver, and then whatever reasons, like in terms of here, you saw that patient had developed, reactive oxygen species and hepatocellular damage. So anything that leads to damage to hepatocytes, right? There is generation of is activation of hepatic, progenitor cells, hepatic stellate cells that ultimately, gets activated, release some fibrous tissue and leads to starts replacing the normal tissue with the fibrous tissue. Right now, this is where the fundamental principle I'd like to come to here. Right now, healing can take place in two ways. In fact, many ways, but two principal ways where you need to see here. One is normal healing, and second is healing by fibrosis. Okay, so healing, normal healing, you have, let's say you have an injury to the, let me give you a corollary. Let's say your injury to the skin. Okay, so you have some, abrasion or trauma or whatever. Let's say you have abrasion. Now, normally, right, there'll be some amount of fibrosis, but generally the entire skin gets replaced and all the tissues get replaced. But let's say some people develop keloids, some people develop other kind of skin conditions, right? Let's say there's a lot of burns. So in this situation, the healing cannot take place normally, and healing starts taking place with healing by fibrosis. Now, fibrosis is basically what it's trying to do. It's basically temporary bridge tissue. But in some cases, you cannot replace that with the normal tissue. And hence this temporary bridge tissue, the fibrous tissue remains. That's the unfortunate part, because the fibrous tissue is basically plastic, it's dead tissue, right? So that is what happens. And this fundamental principle, this problem happens in all metabolic conditions associated with diabetes and all metabolic disorders. Same thing happens in the heart. So you have the epicardial and pericardial fat that goes under inflammation. Then there is all the same process happens. And then there is healing by fibrosis, especially in diabetic patient. Same thing happens in kidney. Same thing also happens, and I tell you, also happens in frozen shoulder, right? There is healing, there is recurrent trauma, and diabetic patients, why they develop more frozen shoulder? Because the healing takes place with fibrosis. There is healing by fibrosis. There's a link in all these things. You can see the link here, right? And the link basically tells you that in diabetic patients, especially when you have all these situations, so when you have NAFLD with diabetes or MASLD with diabetes, you tend to have a double whammy where the patient is more likely to develop progression to fibrosis. Okay. What about platelets? They again stimulate the hepatic stellate cells and release pro-inflammatory, prostaglandins. And again, this is where aspirin use may have some benefits, right? So, I mean, there are no clinical trials, but what I'm saying is, from a pathophysiological perspective, what you have to understand is that aspirin may have some role, especially in these patients, because so if you're anyways, undecided on aspirin and probably leaning towards prescription, if you have a patient with MASLD, especially if you can recognize some elements of steatohepatitis, then probably should consider giving aspirin because it has, from a pathophysiological perspective, beneficial, right? So let's recap what we learned in terms of pathology. I think this is the most clear pathology understanding you can have of this disease. You have fat accumulation. So if it starts from adipocytes, leads to fat in the released, fatty acids being released because of insulin resistance at the adipocyte level. It goes to the liver. On the liver, there is accumulation of fat. There is beta oxidation of fatty acids, which lead to reactive oxygen species, which lead to hepatocellular damage. So far, so good, fine. It can heal back, but sometimes it heals by fibrosis because of activation of hepatic stellate cells and the role of platelets and hepatic progenitor cells, and that ultimately leads to fibrosis, and fibrosis is what leads to the progression of the disease. Okay. Second very important thing you have to understand at this point is the two-hit theory. So if you are trying to understand hepatology, this is your first foray into hepatology, understand this principle very clearly. In the liver, if you have one pathology, it still can go back. But if you have two pathologies, you are doomed. Okay. For example, if you have metabolic, you have already having MASLD and you have excess alcohol, though technically classified as alcoholic liver disease, the disease will progress much faster. If you already have hepatitis C and also have alcohol intake, the disease progresses faster. If you already have MASLD and you develop hepatitis B, the disease progresses faster. So please understand this concept, right? Two diseases to the liver are extremely devastating to the liver. Okay, so one disease, fine. Two diseases, trouble. So please remember this fundamental problem with the liver, right? And another very interesting, important emerging area of research is that the genetic aspect. And there is one particular genetic variant, this one, PNPLA3, one particular SNP, which has significant risk of fibrosis. So all patients who have MASLD do not progress, but there's certain variants of MASLD which progress faster. And this particular variant is known to be particularly devastating. And this again has been found in Indian patients. So this is what happens in terms of risk. So we have this PNPLA3, NFLD leads to, so if you have MASLD and you have this genetic variant, you're more likely to develop fibrosis, also more likely to develop other complications like type 2 diabetes, coronary artery disease, kidney disease. Again, what this gene basically does is it basically, the healing by fibrosis is more with this genetic variant, right? So any of the disease which you talked about I'm not sure if you do a clinical study, but probably even these patients, if they have diabetes, they'll also have more of frozen shoulder, right? It's very interesting correlation. Again, research idea. So any young people listening to this, maybe, this could be a research topic for you, right? Is this found in India? Yes. So this genetic variant is found in Indians also. And again, it's important. So again, it has link with higher, likelihood of having higher FIB4 scores and other complications more likely. There are now other emerging areas of research. There's role of gut microbes, which is now being thought, right? Why gut microbes? Again, it's not very clear, but there are certain theories. So one theory is that certain gut microbes are very efficient at nutrition extraction. So they have more nutrition extracted from the same food, and hence you have more obesity. They contribute to chronic inflammation. We already saw inflammation is a problem. Sometimes they contribute to leaky gut, so there is more endotoxins being absorbed. Some of them lead to free fatty acid generation. And we already saw circulating free fatty acid, what happens to them. And they sometimes alter the bile acid metabolism. Bile acid also has an endocrine, correlation, right? So this is where we talk about bile acids. And bile acids basically, bile acids are in a way feedback mechanism. This is what there is something called FXR. Okay, so there's an FXR receptor, right? Very simple feedback mechanism that I'd like to explain to you. So normally in a healthy liver, so you have less lipids. So again, remember there is fat in the liver. Okay, now what is the signal of fat in the liver? So you have, the bile acids being released, right? To kind of remove this fat from the liver. Okay, so this bile acids, so more bile acids you have, right? It's a signal that you have more fat in the liver, right? And then there is a negative feedback. So this bile acids go and act on the FXR receptor, telling the receptor that we have removed the fat, right? And then FXR then stops the release of further bile acids. So it's a negative feedback cycle that is very similar to other feedback cycles, that feedback loops that you see in endocrinology. But if you have more fatty liver, more free fatty acid goes, right? More of that, and then there is overwhelming of the FXR also. So there is some emerging area here, and fatty acid are signals, but then there is now some correlation that there is alteration in fatty acids also could be correlated with the more disease progression, and it also can lead to gut microbe disruption, and gut microbes disruption can lead to fatty acid changes in fatty acid also. So this is an emerging area of understanding. Not much thing is still known about this, right? And it's an area again which is now emerging as a part of research. Also very important, and I already discussed this earlier, right? MASLD has correlation with other metabolic disorders also. So if you see the recent Lancet Commission report on obesity, they've changed the definition of obesity. Now, obesity is no more defined by just BMI. Okay, remember this, that this is what the new Lancet, this chart really tells you about the new Lancet Commission. So let's say you have any clinical confirmation of abnormal fat mass, right? So abnormal fat mass could be confirmed by either increased BMI or with increased waist hip ratio or waist to height. So we discussed this in some of the earlier lectures, if you had seen in the EarMed lectures also on obesity, we had discussed this area. Right now, if there is clinical confirmation of abnormal fat, if there's no fat, there is no obesity, but there is clinical confirmation, then there are two types of things. One is preclinical obesity and other is clinical obesity, right? So what is the difference? Okay, so clinical obesity means that why this is important, because in future, now they're going to, the drug companies are going to target a particular group of patients in obesity, because obesity now has become, is now treatable, and there's a lot of emerging treatment. So that's why it's very important to define clinical obesity. So clinical obesity means that there is increased adiposity. So you have increased BMI or whatever, with evidence of reduced organ or tissue dysfunction due to obesity, which leads to some sort of morbidity and mortality, and it can impact the day-to-day lives of the patient, right? So that is what ultimately clinical obesity means. Meaning what? Let's take it from, not from a global perspective, let's take it from MASLD perspective. So if you have, let's say, BMI of 32, just having fatty liver is not enough. If you have BMI of 32 with fatty liver with evidence of steatohepatitis or fibrosis, you are said to have clinical obesity. Okay. And just by this, let's say in future, drugs are now given to you, and let's say some insurance company reimburses your claim for anti-obesity drug. What they will say is, sir, do you have obesity based on the adipositive criteria? Yes. But do you have clinical evidence of any organ involvement? Yes. You have MASLD with fibrosis. So if you are having MASLD with fibrosis with BMI of more than 30, you will qualify for a particular group of drug based on the maybe clinical trial or based on some insurance assessment. So this is the fundamental principle, and that's why MASLD forms a very important component of the clinical obesity definition, right? So that's why it's very important. Remember, you have obesity at one place, adiposity at one place, that is in the liver, you'll have adiposity elsewhere as well. So you already, let's say, already have this, you'll have adiposity elsewhere. So you could have, what is known as in the lungs, Pickwick-Arnhem syndrome, you could have obstructive sleep apnea. In the kidney, you remember there is fat in the kidney also, there is renal sinus fat, which leads to microalbuminuria, just like in diabetic patients. If you're a female, you could have PCOS, right? If you're a male, you could have male hypogonadism, right? It could, of course, lead to already saw upper airway obstructive sleep apnea. Cardiovascular system, we already know how fat correlates with that, right? Some of these patients have recurrent chronic urinary incontinence. Musculoskeletal system, they are more likely to have osteoarthritis of the knee joint, right? And lymphatic system, the patients are more likely to have lymphedema. So this is the ultimately, so you have one, problem, just like in autoimmune disease, you have one autoimmune disease, you're more likely to have others. Same way, you have one organ involved in adiposity, you're more likely to have other organs also involved in adiposity. And how does this correlate with diabetes? And this is a fundamental change in our thinking of type 2 diabetes. Type 2 diabetes now should not be considered a disease of pancreas or disease of insulin resistance. It should be considered disease of ectopic fat, right? So the fundamental principle in 2025 you should understand is that you have fat in the liver that leads to central insulin resistance. You have fat in the pancreas that leads to beta cell dysfunction, and you have fat in the muscles and adipocytes that leads to peripheral insulin resistance. And all the three, when combined, ultimately leads to imbalance between insulin production and insulin resistance that leads to type 2 diabetes. So the fundamental principle of type 2 diabetes also gets connected with adiposity. Okay. And remember, it's not just adiposity, it is adiposity that is fat under duress. So if you have a large number of adipocytes, that's what happens with pioglitazone, right? So pioglitazone, what it does is, like I told you about the corollary between the movers and packers bringing boxes, pioglitazone is that guy, is that friendly neighbor who says, "Arey tumko box chahiye, mere paas 5 box pade hain, le jao," right? So let's say you have a lot of material to transport, and your movers and packers has brought only 3 boxes, but you probably need 7. So you ask your neighbor will give you 4, right? Neighbor is pioglitazone. Okay. So neighbor gives you 4. So then what happens is that you are then able to equally distribute your items in all the 7 boxes. Now, if your neighbor doesn't give you something, then you will have to fit everything in that box, and then there are chances of all your stuff being spilled during transportation. This is what really happens in your, ultimately in disease process, right? So less number of boxes to carry the items or less adipocytes to carry the fat leads to fat under duress. So either you have more items or less number of boxes, right? Mostly more items. On the other hand, it's the other way around, where you have large number of boxes, right? Boxes number increase, and fat, whatever amount it is, right? Doesn't matter, right? Your material you can equally distribute amongst the 7 boxes, and hence you don't develop your item can easily be carried by your movers and packers, and it is less likely to spill and fall and get lost, right? So that is the fundamental principle of pathology and pathogenesis. Now I'll stop the second presentation. We have one quick third presentation. Before that, we'll take some questions. There are plenty, I see. Okay. Let me run the quiz meanwhile. Okay. So that you can start answering. There are 4 questions. Let me just run through you the 4 questions. First question is a 45-year-old male patient with obesity and type 2 diabetes presents with elevated liver enzymes and suspected to have non-alcoholic steatohepatitis. Ideally, again, this term should be MASH, not NASH now. What are the histological features essential for confirming diagnosis of NASH? Okay, so we discussed this. I'm waiting for you to answer. Second question is, why is steatohepatitis considered critical focus in management of research of MASLD? Okay, this is question number 2, right? So you have 2 questions here. Yeah. And third question is, what is the primary mechanism by which insulin resistance contributes to accumulation of fat in the liver? Okay, so these are the 3 questions. Okay, so while you answer this, we'll be taking some questions from the poll. And Dr. R.D. Anand has said how to quantify locally made alcohol. Well, you know, it's almost similar to the thing, right? There are, again, Indian standards for that also. So you can probably search on the internet, you'll get it. But it is just an approximation. So, you know, it need not be, you know, perfect, right? It's an approximation. Okay. Right. So let's, so Deepak Kumar, if you have a question, you can put it in the Q&A and I'll try to answer it. How do we find the notes and lessons? Is it through app or website? I already answered this. You need to go to technocrinology.com. I'm typing the answer. So you need to go to Technocrinology. You would have also received the email. Email would have all the instructions. But otherwise, you can go to technocrinology.com and you can, you know, access it. Whether beer consumption is, Bhaskar has asked, whether beer consumption is more a risk factor than alcohol, and also more details of limits of alcohol consumption. So alcohol is not our primary point of discussion today. You know, I'm sorry. We're mainly focused on MASLD. The reason why we discuss alcohol was so that now, because there's an integrated definition here, maybe we can have a separate session on alcohol and its issues, right? So, yeah. Okay. Then we look at Chandan Kumar, who says, do these terms, MASLD, METLD, ALD, signify different diseases with clear differences in pathology or clinical basis, or just classifying them for our convenience? Oh, it's a great question. That's a great question, Chandan Kumar. To answer this, remember, there are practical aspects of it. First of all, there is research aspect of it, right? So let's say you're doing a clinical research on a drug which is, you know, which you want for MASLD. So in that case, you will have to quantify the alcohol intake, and then you will have to remove the patients with significant heavy alcohol intake. So it has used in terms of clinical research. Secondly, it has used in terms of, you know, again, remember, some of these patients will go on to develop required transplant. Now, in certain countries, there are certain different regulations for alcohol-related diseases, right? So again, transplant would have clinical connotation, right? Again, alcohol intake, so excess alcohol with MASLD, like I already told you, will have more progression of the disease. So hence it is important. Hence it is very important to quantify the alcohol intake also. Finally, I'll say in terms of insurance companies, now let's say there is a drug developed for MASLD. The insurance companies can say that I will not, you know, allow this drug for, or I will not reimburse this drug for patient with alcoholic liver disease. I'll reimburse this drug for patients with MASLD, right? So there might be some, you know, in future, whatever, you know, drugs that come, there might be insurance companies. These are going to be very expensive drugs. So the insurance companies may or may not lay claim to that, right? So that's the answer. Okay, can you remove the record box that is hiding the, okay, I'll try and do that. Okay. Right. Okay, Dr. Ashish Saxena has asked, what is the role of FIB4 score? Okay, so FIB4 score is mainly for fibrosis. We'll be discussing in great detail, sir, FIB4 score in the coming lectures. Take it easy. We are going to, you know, we have divided this into 4 parts, 4 lectures over a period of 4 weeks. So we have plenty of time. We'll discuss FIB4 in more detail. Okay. Weight loss is beneficial, but rapid weight loss is not, right? So Chandan Kumar, okay. So how do we define rapid weight loss? And what is the differentiating line between beneficial weight loss and rapid weight loss? I think there used to be some formal definitions of rapid weight loss. I don't remember the current definition of there. But I guess, you know, generally, if you see clinical trials in the current safe, quote unquote, safe weight loss criteria, generally it is said that 5 to 10% weight loss over a period of 3 to 6 months is considered to be safe. Now, if it is, let's say 20% over 3 months, you're losing, that's a rapid weight loss, right? So I'm currently not aware of the current, you know, definition of rapid weight loss. I'll check it up and we'll try to answer that in the next lecture. But, you know, but yeah, you know, there used to be, but generally 5 to 10%, and clinical trials also want 5% to 10% weight loss over a period of 3 to 6 months. So that's generally what clinical trials consider, and that's just generally considered to be safe. Now, what is the reason for rapid weight loss leading to MASLD? What is the generally that deals more with the with the cholestatic picture. Remember, remember you have when you have rapid weight loss, you also have start developing a lot of cholestasis. And this cholestasis can lead to cholestatic liver disease also. So that's the reason why. And that same thing happens with gallstones also. So you have rapid weight loss, you have more gallstone formation because of cholestasis. Okay. Can you have the YouTube link for the lecture to refresh ourselves? Yes, so you'll receive an email with the YouTube link and everything. And you can again go to technology.com and you will get the lecture there, and you will find all the reading material, whatever I talked as notes, and you'll get all the stuff as a video also, right? Can you put more light on aspirin use? Yes, so like I said, one of the pathophysiology thought is that aspirin, because of the platelet-derived growth factors, aspirin probably inhibits that, and that's why probably has protective effect. Some of the there are early clinical trials which looked at aspirin for, prevention of progression of NAFLD. In fact, there are trials for alcoholic liver disease also with aspirin, and there's some benefits to it. But let's say you have a patient and with probably primary prevention with aspirin generally is now disregarded, but you have a high risk patient, then maybe you should consider giving aspirin. That is the thing, So ultimately, it's not a hard and fast, and there's no hard and fast rule to it, but that's the whole idea. Okay. So if in the last lecture on management, we'll probably take a word on aspirin also. So it's I'll keep that in mind. PCOS and menopause, insulin resistance leads to MFLD. It's not one leads to other. Both are correlated. Both are coexisting, right? So generally, it's not one leading to other, right? So it's not. Correlation does not mean causation. So there's generally correlation. There is no causation. Okay. From pathophysiological perspective, somebody said excess adipocytes is beneficial. So excess adiposity is not synonymous with. Oh, okay. So yes. So excess. Like I said, the definition now is very clear as far as Lancet is concerned. What they say is, Lancet Commission is concerned, they say that there is clinical obesity and there's preclinical obesity. So if you have adiposity with organ disease involvement, right, then it is basically clinical obesity. But you don't have organ involvement and yet you are obese by the traditional definition, it is fine, right? So you don't have to worry. So that's what they're saying in the new definition. Okay. Visceral and parietal fat, what is more associated? This is all visceral fat, right? Visceral fat is the damaging one, but this is not visceral or parietal. This is basically ectopic fat. Okay. But if you talk about which is linked with MASLD, visceral fat is more linked with MASLD. Any specific meds? Yes, we'll discuss that in chapter 4, 4th week in great detail. Is pioglitazone, metformin more useful or pioglitazone in case of grade 1 fatty liver? We'll discuss that. If subject is with pre-diabetes, we'll discuss treatment. We'll discuss in the upcoming lectures. Okay, let's go back to the polls and quizzes. Okay, let's end the poll. Share the results with you. Okay, so the first, most of you answered correctly. So you have steatosis, inflammation, and hepatocyte ballooning. That is the definition of steatohepatitis. The second question was, why is steatohepatitis important? Because, like I said, it's the key inclusion criteria in clinical trials, and it's hence becoming a very important area of thing, which again, most of you answered correctly. What is the primary mechanism by which insulin resistance contributes to accumulation of fat in the liver? This we already discussed. So insulin resistance promotes uninhibited lipids, and I think again 78% have given the correct answer. Right? Okay. Yeah. So moving on to the last lecture of today. Short, quick lecture. I hope you really enjoyed it. I can see a lot of people still engaged with this, and this is great. Let me then go to the third lecture. That is liver as an endocrine organ. Okay. So now we move on to the subject of liver as an endocrine organ, again from a pathophysiology perspective. We'll discuss the treatment. We'll not be discussing treatment, diagnosis, everything. We'll discuss we'll discuss in some of the upcoming one or more of the upcoming lectures, right? Some of the things also, key principles will be, refreshing in our next lecture also. It's going to be a very detailed, aram se understanding of MASLD. I hope, your time is justified. And I think probably after end of this, you will not need any more, lectures on this for a while, right? So that's, I promise you that. Now, liver is an endocrine organ, right? Adipocytes are endocrine organ. What are the hormones produced by liver? Well, insulin-like growth factor. So again, endocrinologists here in this audience would know that IGF-1 is produced by the liver. We have angiotensinogen, thrombopoietin, hepcidin, a lot of them, right? Now, why this area? Why this topic has now become important? Because of all the potential therapies which was potentially available for liver, MASLD, the one which got first approved internationally was resmetirom. Resmetirom is basically a thyroid analog. Okay, so this is a thyroid, it acts on the thyroid hormone receptor beta, and hence reaffirming and prioritizing the role of liver as being an endocrine organ, right? Because the first approved drug for MASLD by the US FDA is an endocrine drug, right, which is resmetirom. Now, why do you need to understand this? So what I'm trying to say, and using thyroid as the prototype, we're going to understand how a lot of these endocrine systems work on the liver. I will mainly discuss right now with the thyroid. We already discussed with insulin resistance in the last lecture. Now we'll discuss more from the thyroid perspective. Now, there are two types of thyroid receptor, right? So you have TSH receptor alpha and TSH receptor beta. Alpha 1 is present mainly in heart and bone, beta is present in the liver, right? So basically what happens, you have the, not TSH is a thyroid hormone receptor alpha and beta. Now, resmetirom is a thyroid hormone receptor. This is wrong, okay? So I'm sorry, this is not TSH, it's thyroid hormone receptor alpha and beta. Resmetirom is a selective liver hepatic selective thyroid hormone receptor beta agonist. So it goes and acts the thyroid hormone receptor at the level of the liver. Okay, that is what primarily it does. Now, let's go back a step back further. What is the link between the liver and the thyroid? Okay, so it has always been known that subclinical, and again, a lot of these terms use NFLD. Please use the word MASLD. This was a slightly old presentation, which we sort of reused it, but the correct term now is MASLD. Okay, so just to be clear, subclinical hypothyroidism was known to have higher prevalence of MASLD. Overt hypothyroidism definitely had more MASLD. In fact, overt hypothyroidism would often present to hepatologist or a gastroenterologist with complete liver dysfunction type of picture. Again, it is known that higher TSH, more progression of MASLD. There is increased per se presence and increased risk of progression also. So this is a clear link, right? Now, so you would ask me, chalo, theek hai, got your point, right? You have, thyroid has link with, so people who have higher TSH, right, have more likely to have MASLD, and more likely to have progression of MASLD. So why not just treat them with thyroid hormone? Simple, right? You'd say, why not just give them? Now, if you have subclinical hypothyroidism or overt hypothyroidism, yes, you are justified. But if you don't have thyroid dysfunction, and if you give, let's say, T4 or T3, this will act on both the receptors at the level of the heart, at the level of the bones, and also at the level of the liver, right? So now at the level of heart, let's say I am theoretically, so let's say from a theoretical perspective, I have a patient with MASLD with normal TSH. Let's say TSH is 2.1, okay, normal. So let's say I have heard that thyroid hormone is helpful for treatment of MASLD. So let's say I give this patient T3, not even T4. Okay, if I give T4, T4 gets converted to T3. But let's say we give T3, right? Why T3? Because T3, there's a conversion aspect also in the liver, which we'll come to. But let's say we give T3 and not T4, right? So let's say this, right? Now this will act on the TR alpha, thyroid receptor alpha, and thyroid receptor beta. Now this is present in the liver, and this will reduce MASLD, right? But this is present in heart and in the bones. And we know that excessive stimulation of this receptor at the level of heart can lead to increased risk of arrhythmia, and in bones, it can lead to increased risk of osteoporosis. So you can treat this patient with T3, but on one hand, your liver becomes better, but on hand, you are putting the patient at risk with liver and the heart and bones. Get my point? So the point here is just give a drug, and that's where resmetirom comes. You just give a drug which acts on this and not on this. Okay, so give a selective TR beta agonist. Simple. That's the fundamental principle of resmetirom, right? We'll discuss resmetirom again in the treatment aspects later. Now, so like I said, giving T4 or T3 is not justified, but giving resmetirom is justified because it is super selective to TR beta. Now, why do patients with liver, why does the liver have correlation with the with the thyroid? Now, there is something called deiodinase. Okay, so the hepatocytes convert. So remember, T4 is a prohormone, and the actual hormone is T3. So T4 gets converted to T3 by hepatocytes by type 1 deiodinase, and the stromal cells, they do a reverse conversion. It converts T4 into reverse T3. Now let's say you already have MASLD, you have fat deposition in the liver. There is damage to hepatocytes. So there's damage to hepatocytes. There is less amount of hepatocytes and more generation of stromal cells. So because you have less amount of hepatocytes, the T4 to T3 conversion does not take place. And more of T4 to reverse T3 conversion takes place. And because of that, this sets up a vicious cycle. So you have again less amount of thyroid hormone acting on the liver cells. And because of that, you have intrahepatic fat deposition, and that leads to lipotoxicity, and that again leads to more hepatocyte damage. So this creates a vicious cycle. Okay. So that is what is known as intrahepatic hypothyroidism. And this is the emerging concept in thyroid. So this is also known as thyroid liver axis. Right now, you take a patient with, let's say, TSH. We saw a TSH patient with normal TSH. Let's take a patient with TSH of greater than 100, let's say, right? Very high TSH level. A very high TSH level will mimic a complete liver disease. So if you've seen such patients, you'll find that these patients have very high SGPT, SGOT will be hundreds. Patient will also have, may also have ascites, myopathy. So these patients can actually mimic a full-blown cirrhosis of liver. And sometimes, you treat that there'll be dramatic improvement with this, right? And also very interesting, there are studies which are looked at free T3 to free T4 ratio. Somebody asked about, Dr. Saxena asked about FIB4 score. There's another score which is very useful. That is free T3 to free T4 ratio. And this free T3, free T4 ratio is found to have very strong correlation. You can see the p-value here. Very strong correlation with hepatic fibrosis progression, right? Why free T3, free T4 ratio? Because if you have more damage to hepatocytes, you have less T3 formation in the liver, right? And more T4. And hence, this free T3, free T4 ratio, a lot of it gets produced by the liver. Free T3, free T4 ratio also has clinical correlation with the risk of developing fibrosis. Again, this is just for your interest. Now, I have one theory. Okay, I have not done any clinical study to prove this, right? Again, this is completely an expert opinion. I'm just repeating this complete expert opinion, right? But ideas, that is how ideas spread. Again, there'll be a lot of young people in the audience who want to do a clinical trial. This is something worth doing. The point here I'm trying to make right now is resmetirom is probably never going to come to India. Even if it does come to India, it's going to be a very expensive drug. In the US market itself, it's a very, very expensive molecule. How many patients are going to afford, right? And MASLD affects 30% of the world's population. I'm sure Indian population is similar. It is similar, right? How many patients of yours are going to really afford resmetirom? Not much. So what could you do, right? Now, one thing you could do is, I think what I'll suggest is that screen these patients for hypothyroidism. If the patient has TSH more than 10, patient has subclinical hypothyroidism. What is subclinical hypothyroidism? TSH, which is elevated, but T3, T4 are normal. Whether to treat these patients or not, that's the area of debate, right? So it's again, we sometimes do NT-TPO antibodies, and that's a complete chapter in itself. But what I'll suggest is, if the patient is having TSH more than 10, anyways you treat, that is generally the norm. If the TSH is between 4.2 to 10, you look at the patients, having NASH or NAFLD. So you have a patient with subclinical hypothyroidism with NASH, NAFLD or MASLD, you should consider treating this patient. The argument here is that Subclinical hypothyroidism to treat or not to treat is an area of debate. But already you know from evidence that patients who are, and generally again, well, you'll say, why would you give T4? Because T4 will not get converted to T3 here. Maybe consider T3 in form of treatment, right? So again, this is an argument's sake, right? Again, area for potential clinical research. This is not an area for, you should start doing in your practice, but the idea is that this is something you could consider as a part of clinical research, right? This is an idea for research again. So for somebody who are, some of you might be mentors for thesis, you could give this as a topic to a student, or if you're a student, this is a topic you should consider giving, right? T3 is now available in India. So take patients with subclinical hypothyroidism, TSH of 4.2 to 10, and look at presence of SGPT, SGOT elevation, look at for fatty liver, and then see the progression of the disease, right? So that's something you can consider treating. So I end here, right? It's, as I promise I probably overshot my time also. It was supposed to be 1 hour. I thank you all for being there till the end, right? And I, glad that, you attended this. We are having the next session next week where we are going to discuss about everything about screening diagnosis. So we'll discuss about everything about SGPT, SGOTs, liver function test, ultrasounds, all those things, right? And then FIB4 score also. And after that, we are going to discuss about the radiology aspects mainly. So we'll be discussing a lot about, a little bit about ultrasound again. We'll discuss about the third chapter. That is where the hands-on in the sense more of practical. We'll be discussing interpretation of fibroscans and MR images, MR elastography and all that in MASLD. And then finally, the last chapter will be discussing everything about treatment. Okay, so this is how we are going to, kind of break away the chapters. So, please attend the next one as well. I hope you really enjoyed it. Let's take some questions which are there. There are no quiz question for me right now. So okay, let me just try and answer all the questions which I can right now. Okay, so let's start with Shashidhar Reddy. I think we already answered that question. Okay, Hridaynath has asked any specific meds that will help in, or we already, we'll discuss this later in the fourth lecture. We already discussed about Pathogenesis. Okay, so I have one new question. Again, if you have more questions, please feel free to type. And again, if you now have a question or have a comment or suggestion, please raise your hand and we'll allow you to speak also. So we'll be happy to, have you speak also, allowed to talk also. Okay. Okay. So Chandan Kumar has asked, so does it imply patient with hypothyroidism MASLD will not respond to usual dose of thyroxine and improving MASLD can? Oh, great. That's a good question, actually. That's a good question. I will say maybe not. There will be some amount of hepatic resistance. You're right. Because the T4 conversion to T3 conversion does not. And that's why there is still a very strong argument for considering T3 as a form of therapy. The only problem with T3 is that it is a very short half-life. And also the cardiac risks are not very, very clear about T3 medication, right? So I think you are right. Having said that, when you give high doses, so when you give supraphysiological dose of anything, it kind of, you're giving a lot of T4. Yes, you have less type 1 deiodinase, but you still have type 1 deiodinase. So yes, there'll be some refractoriness, but at the same time, there'll still be some response to treatment. So, yeah, I hope it answers your question. But yeah, so that's the idea. And Chandan Kumar said, I saw your online class in IMS in 2030. Okay, great. So, and thank you so much. Thank you. Yeah, thank you, Chandan Kumar. Thank you so much. And I think, yeah, I've been teaching. So why hepatology? Actually, my first love was hepatology, and I ended up becoming an endocrinologist. I used to teach hepatology in IMS, which is a PG teaching class long time back. So thank you for bringing those old memories. I hope you had a good learning experience today. And thank you for attending. And we hope to see you next week. Okay, go to technocrinology.com. Okay, that website is Technocrinology. Again, let me just take some time. Just give me 1 second. Quick second. Just share. Okay, so you have to go to technochronology.com and go to this LIPAGLYN MASLD Pro. And then you go to the course, and this is where you'll find all the course content. Okay. And the course content and all the notes and thing. And we'll be uploading this presentation as well as we'll be uploading the presentations, as well as we'll be uploading the the lecture also, the recorded video also on this system. You can also go to our Endocrinology India YouTube channel where you'll be finding this same lecture. Okay. Okay. Any effect of cortisol on testosterone levels in fatty liver progression? Yes. Okay. So again, cortisol, yes. So patient has patient has a hypo Cushing syndrome, yes, right. Testosterone, yes. Hypogonadism as linked with things. So yeah. Okay. What book to read along with your lectures? Yeah, I think, well, you can probably consider using, I would say the topic has changed a lot over a period of time. So I would probably, not stick to a book. I probably look at some of the recent lectures on recent review articles on the topic. I think now there is a MASLD guidelines available. We'll be putting some useful resources in the channel also. Mainly, I'll stick to some review articles. There's one very beautiful review article published recently called Steatotic Liver Disease in Lancet. Okay, so if you have get access to that's a great great starting point to read a lot of these things, right? So rather than reference book, I would say better to read on, because MASLD is a topic which is fitting somewhere in middle, right? So great. So okay, so I think we can end here, and thank you for attending, and thank you for listening. Okay, when will Endocrinology Notes Volume 3 be available? Let me just finish that. We started the work on that, but it's not finished, but it should be available soon, hopefully. Thank you.